So resected salivary gland. And Tiranjan, focus question to you. When will you consider giving radiation to the patient? So this factor, we will give radiation.
So for all high grades, like already Monali has highlighted very nicely, all high grades, all adenoid cystic type, these adenocarcinomas, expleomorphic, and then in the intermediate one with the high risk features like going to T3, T4, close margin.
Let me stop you, Tiranjan. So if there is a T1, N0, M0 high grade, gets radiation?
Adenoid cystic, probably yes. T1, N0, M0, adenoid
salivary
cystic.
duct carcinoma, mucoepidermoid, because mucoepidermoid is the commonest one.
Mucoepidermoid is bit query because it is, though it is high grade, then T1, very tricky to take a call.
So we can say T3, T4, any grade,
Definitely.
or T3, T4 low grade, you will leave it.
No, T3 low grade with T3, T4 is a high risk features for low grade.
So T3, T4 irrespective of the grade, node positive irrespective of the grade.
Yes.
Okay.
And certain histology irrespective of size.
Yeah. In T1, T2, if it is a high risk histology, we will go for this.
Yes.
Is that I'm summarizing correctly?
Yes. Yes.
Adjuvant radiation, what would you give the dose and what would be your technique?
As of now, the technique should be IMRT for these patients. I think we have moved past the combination of photon, electron, and the double wedge 3D CRT technique. Dose for the dissected tumor 60 gray 30 fraction and elective nodal volumes 50 to 54 gray in 30 fractions given as a simultaneous integrated boost.
Okay. So one question: elective nodal radiation, what would be the volumes?
1B, 2, and 3, and the pre-parotid nodes. So that is the what ipsilateral.
1B, 2, and 3. When you would consider going for level 5 or contralateral lymph nodes?
Contralateral almost never in parotid glands. Ipsilateral, if there is heavy nodal burden in 2B and 3, then 5. Otherwise not.
Okay. One question, and Richa is there? Or?
Yes, Dr. Vijay, I'm there.
Yeah. Richa, let's say adenoid cystic comes, there is a 4 centimeter lesion in the parotid, there is one lymph node in level 2, and there are 3 lesions in the lung. Do you want to still operate this patient or you don't want to operate this patient?
So a couple of things that I would consider before I offer the surgery to this patient. One, I would like to know what is the grade of adenoid cystic carcinoma. And second, not only the 3 lesions, I would also like to know what is the size of the lesion. So if there is a very large metastasis and large lung volume is compromised, I am not very keen. It's a high grade. But say very small 3 lesions and it is a intermediate low grade, or for that matter even high grade adenoid cystic carcinoma, I'll be a little skeptical for high grade, but for low and intermediate grade, I would like to go ahead with surgery in this case.
Okay. So for so the message is that if it is low grade, if the lung nodules are small, you would still operate this patient. Would your decision change if this was, let's say, mucoepidermoid or salivary duct carcinoma or the mammary secretory analog type of carcinomas?
If it's extremely high grade with guarded prognosis and limited life expectancy, I may not be very inclined towards surgery.
Okay. Dr. Neha, let me get you here. So can you just, for the benefit of the students who are, can you just tell in simple words, high grade, which are the high grade histologies and which are the low grade histologies?
So high grade histologies, thank you Vijay for that question. So high grade histology, the first and foremost to remember will be salivary duct carcinoma. That is the highest grade histology, right? Then there are high grade variants of almost all the salivary gland tumors. They are high grade stroke high grade transformation. For example, some tumors have categories in which they can be low and high. Example being mucoepidermoid. There is a variant in which mucoepidermoid is high grade. And otherwise, adenoid cystic can have high grade areas in the form of solid areas. So right now, we do not do any grading for adenoid cystic. The adenoid cystic is divided into low grade, which means the ones which do not have any solid component, and the ones any solid component if present, that is a high grade adenoid cystic, and it has a higher grade in which you can have high grade transformation, which means adenoid cystic from a biphasic tumor can convert into a run of the mill high grade adenocarcinoma. So in salivary gland, we have to understand three concepts: low grade, high grade, and high grade transformation. Right? So, as I said, then you were talking about high grade tumors. So mucoepidermoid high grade, adenoid cystic solid or high grade transformation, salivary duct carcinoma, high grade variants of almost all. Acinic cell carcinoma can show high grade transformation. Hyalinizing clear cell has been reported to show high grade transformation. Otherwise, the usual run of the mill variants of these secretory carcinomas, epithelial, myoepithelial carcinomas, usual adenoid cystic carcinomas, secretory carcinoma or mask. Secretory carcinoma and mammary analog is the same tumor.
Yeah.
It was initially caused as mammary analog and now called as secretory. They are all usually low grade tumors.
Okay. So one more question here. Like as you correctly pointed out, these tumors can undergo high grade transformation. So let's say that the person gives an history that the swelling was for a long time and now he has delayed it to coming to a surgeon for let's say 2 or 3 years. And now when you do a scan, you see lung nodules also. Would you recommend doing a lung biopsy to see that whether that's a transformed a lesion, or you would say, okay, no, but if this shows low grade or intermediate grade, we should take it as that?
This kind of are you asking me, Vijay?
Yes, presume.
So see, this kind of a situation is most common, right, in a carcinoma X pleomorphic adenoma, right? In that case, looking at the imaging, okay, it is the invasive component. The pleomorphic adenoma is usually in the form of a hyalinized or a calcified nodule in such cases, right? And it is the aggressive component if it is targeted. Then even a primary site biopsy will yield the high grade component. But as we know that the metastatic clone may always be the highest grade of tumor. In this case, it will actually be the amenability of the two lesions and correlation with imaging for areas of high grade histology. A pleomorphic adenoma will not go beyond the gland. And if there is a soft tissue component and that is targetable at the local site, that will also give us the high grade component.
Okay. Richa, one question for you. It has come in the chat box. When do you say that a salivary gland tumor, and let's take parotid for this year, is unresectable?
Okay, it depends upon that how we will have the local site of unresectability. So if it is very, very close to the internal carotid, obviously we know that it is unresectable. Second is, if say suppose we don't have the appropriate reconstruction, even if we are able to excise it and we don't have a plastic reconstruction, it's going into the EAC, it's involving the TM joint. I mean, if you are talking about unresectability, we can excise it all, but we may not have a appropriate reconstruction. So in those cases also, we will have to say that not to operate in these patients. Apart from that, if you are able to excise it, appropriately reconstruct it, we should go ahead with it. And third contraindication to surgery would be, say there is a florid metastasis and you know that it is a high grade tumor with a limited life expectancy, again you call it unresectable or inoperable. Okay.
Dr. Mishra and Dr. Satvik. First Dr. Mishra and then Dr. Satvik. When do you consider giving chemotherapy in an resected salivary gland tumor? Or you don't? So let's be clear, you don't consider any time. And if you consider, when do you consider, and what are the agents you give?
Sir, we do not have good evidence to support the role of chemotherapy in salivary gland tumor. So I do not usually recommend concurrent chemotherapy in salivary gland tumor, sir.
Okay, fair enough. Satvik?
Yes, sir, I agree. Both ESMO and ESCO both state that there is no data to support the use of concurrent chemotherapy in any situation. So I usually do not.
Okay, Sudeep?
Yes, sir, I agree. Whatever data we have, most of them are retrospective series, not randomized control trial, and they are mixed population of different histological types. So I usually don't give, but if there is external extension or margin positive, after explaining to the patient that the benefit is doubtful, I give, though there is no overall survival benefit.
So let me ask you all three a question. So what evidence you apply when you advocate adjuvant radiation? Which randomized study you use?
Yes, sir, it's true. Actually, I think even adjuvant RT, we do not have too much evidence in case of in case of salivary gland tumor.
So this is a rare tumor. You are unlikely to get
No,
an evidence.
it's
Yeah,
not
just
for
say some-
salivary. The adjuvant RT in head neck came for all retrospective series only. There has never been any prospective, so-called we look for randomized
Nana,
evidence.
there is one. It's from
There's
Orissa,
one.
from
Yeah.
Monali's previous
Yeah.
institute. It's
Yeah,
the only adjuvant radiation randomized
yeah,
study in
yes.
locally advanced oral cancers. But whatever
So
said is correct.
I agree with you, Vijay. Maybe we do like extrapolation of in salivary when you have node positive VNE, close margin.
Yeah,
Because
so
the challenge, I
yeah.
feel that the only challenge is that if 5 years down the line we feel that okay, there was some benefit, then what do we answer as a clinician? That maybe I had some chance and I did not apply. So these may be good cohort to apply.
Yeah. So actually there is a difference of, and I just show the A. So so if you see there have been differential results. There have been results which are shown that in high risk features like margin positivity or with external extension or with multiple lymph nodes positive T4 lesions, there have been studies which have been in favor of CTRT. They have shown that there is a local regional benefit and even a survival benefit. And there has been a large amount of evidence which is also against, which have also shown that using CTRT in this things has had detrimental effects. So we need to know about both the level of evidence. And the difference is because many of these are like retrospective studies. Many patients, when they put in CTRT, there were those patients which were put who had either had margin positive resection, large amount of residual disease, hardly any matching done. And even if you do matching, it's difficult to match when, like, and this is what I was telling you, like if patients have received CTRT, a higher amount of histology, a higher amount of poorly differentiated tumors, a higher amount of larger T4, a higher amount of node positive diseases always went in for CTRT. So I think at present we can say that there is no level 1 evidence, that is correct, but in salivary everything is not based on level 1 evidence, and I think we need to have a multidisciplinary discussion here. And I would agree with Niranjan, if a patient has margin positivity or has large number of lymph nodes which are positive, large T4, then if the patient is fit, you should consider at least giving weekly cisplatin. And as pointed out, RTOG 1008 would give the definitive answer, but it has been going on since 2011, if I'm not mistaken. It's already been 12 years and they are not able to recruit these patients. With that, we will just change the gear, and we have at only 5-10 minutes left. So going for palliative therapies. One point we never discuss in palliative therapies, and let me come with Sudhi. When do you decide that this patient needs treatment? Do every metastatic salivary gland or recurrent tumor which is not amenable for a local therapy needs therapy, or you say no, everyone doesn't need therapy? 1, 2, 3, 4, these are the criteria, they need therapies.
Yes, sir. Sir, many of the salivary gland, even in metastatic setting, they are asymptomatic. So first of all, I need to see that whether the patient is symptomatic or not. Next comes that what is the disease tempo? When it means in last 3 months or last 6 months, what is the rate of the growth of the tumor? Now, if I see that the tumor is growing very fast and very soon the patient is going to be symptomatic, if this way the patient, the lung mets are growing or the liver mets are growing, that is the situation I feel this patient will require some systemic therapy. Okay. And of course, I also see the disease histology also, like salivary duct carcinoma. It's very aggressive tumor and they grow very fast compared to adenoid cystic. And adenoid cystic, most of the time they are usually they are very slow growing tumor.
Okay. Question to you. Let's say, is there a size criteria? Let's say that patient has a 2 centimeter lung mass, 2 centimeter lung mass, or a 5 centimeter, 6 centimeter, where you would say, okay, anything about this cutoff I would give. And let Rakesh take that question.
Sir, there is no clear-cut size criteria where we can define. we can see the rate of the growth, and the most important is the histology. What was the histology? So if it is a low grade, we can wait and watch, if especially in case of adenocystic carcinoma, and the low grade salivary gland tumor, sir.
Yeah, I would agree that there is no need to start therapy for this patient. The treatment starting indications are in generally which are considered across guidelines if the patient is symptomatic. If the patient is asymptomatic, then you need to demonstrate that there is a fast growth of the tumor, like a 2 centimeter increase or something of the tempo in the last 6 months. Or if you feel that the tumor at such a critical site that can lead to a visceral crisis. So next question, how many of you do, let's say a palliative case comes to you of salivary gland, you do a comprehensive NGS or let's say look for genetic markers?
Sir, I usually try to get the androgen testing and the HER2 testing. So that is my first criteria to get the tissue from the tissue, because the most of the time tissue is a issue. If tissue is available, then I can go for the NGS, sir.
Okay. Sudeep, Tiranjan.
Sir, in all my patients, I ask for at least IHC for androgen receptor and HER2, at least, in 100% all patients. Now, when if something is not coming out, actionable driver mutation, then only I am in desperate situation to find some next line. Then only I ask for NGS.
Okay, so let's take the situation that patient has come, he is symptomatic, you are sent for NGS, and let's say, I'll give you a situation. First thing, it is a salivary duct carcinoma, and one patient is adenoid cyst. So 2 situations, patient is symptomatic, you have done the biopsy, HPL confirms that one is adenoid cystic, one is salivary duct carcinoma, you ordered for NGS and everything. What would you do in both these patients?
So if NGS report is awaited, and I want to I want a faster symptom control, then for adenoid cystic, I usually treat with CAF.
And for the salivary duct?
Yes, sir. For salivary, yes, for salivary duct, I depending on the patient's, the PS and comorbidity, I use either CAF or even weekly catheter carboplatin. But once the HER2 comes positive, then I can add trastuzumab with that.
Okay. Satvik, you would do the same, or you would consider lenvatinib or sorafenib or axitinib in non-adenoid cystics?
So definitely, yes, sir. While awaiting NGS, and as rightly said by Dr. Sudeep, that we will also look at the tempo of the disease. If it's slow growing, then we can use lenvatinib or sorafenib. But if it's aggressive, then I would go with chemotherapy, definitely.
Okay. The reason why we chemotherapy is, as this was shown by even Khil, that not much responses we get. The best responses are been given by CAP only, and so most of us tend to use it. I would go here a bit faster, and just wanted to show this data. This is still in review for last 2 years and has not yet got published. And so what I wanted to show is that even if you do observation, and if you select an appropriate patient for observation, this was that 9 patients were kept on observation. This data is at the time when Dr. Vikas Talreja was a resident in Tata. So this is very mature data. And this actually shows that a median PFS of 17 months. So just wanted to make a point that if you select your patients properly, you won't, let's say the patient comes NTRK fusion positive. Satvik, what do you want to do?
Definitely, sir. I would like to put the patient on larorectinib or entrectinib.
Let's say he cannot afford it, which would be the situation in 99% of the patient.
Then tricky situation. Then I will refer it to TMH for a second opinion.
Okay.
Compassionate.
Yeah. So the thing is that we tend to larorectinib or entrectinib in this, and recently the data has come even for repotrectinib to be used in NTRK fusion, not specifically in NTRK fusion here. But the thing is that compassionate ground access is available in this patient, even if it's not affordable. That's the reason why I told you that the patient is not affordable, and the company gives it. It causes 86 to 90% responses in this patient. Now, last we'll take anyone has used immunotherapy in salivary gland tumors?
No, sir. No.
No, sir. No.
Yeah.
No, sir.
So this was the response we got. We got a response of 15%, and some, what you would say, average OS. Would you think that it is useful to check PDL1 or A? Because in the keynote study from which this data came, I just wanted to point out that if you look at this data clearly, most of the patients were very heavily treated. Most of them had received multiple lines of therapies. So do you still use this data, or this is like one-off situation? If the patient demands, then only we use it?
I would use MSI only if I want to
Okay.
choose.
So MSI only. Rakesh, how do you use it, or you will also do MSI, and MSI only you will use?
Sir, MSI and TMB, sir, tumor mutation burden. These
Okay,
are
so okay, fair enough. Sudeep?
Sir, only MSI, and that's when all the options are exhausted.
Okay, when all options are exhausted, and if it's MSI high. Okay, there's a question from Amit, and we'll take that. ARL positive ACC progressed on leuprolide and abiraterone and enzalutamide, followed by lenvatinib. What next? So it's progressed on leuprolide, abiraterone, enzalutamide, and then lenvatinib.
So here, I think systemic therapy is an option.
Yes.
There are the vinorelbine and mitoxantrone. The few responses, 10 to 15% we can see otherwise.
Yeah, I would agree with that. In this patient, this is an option, and you may also consider doing broad panel testing if the patient can affordable, because sometimes you get surprises and you might end up getting some target. So this is what I wanted to show, is that the HER2 positivity, and as I was telling you, that most of the salivary duct cancer have a high risk, but others also show some form of HER2 toxicity, which can range from 5% up to 40%. Question: if a patient comes HER2 positive, it's metastatic. How do you decide which agent and how long to do? Satvik.
Sir, I would combine docetaxel with trastuzumab and definitely 6 cycles, and then trastuzumab maintenance the way we do in breast.
Why not trastuzumab, pertuzumab? Because docetaxel, trastuzumab,
definitely.
60% febrile, severe neutropenias are seen, and many a times these patients are elderly. So why not consider giving pertuzumab, trastuzumab? Why not TDM1 from directly?
Yes, sir, definitely. Trastuzumab and pertuzumab can be combined. TDM1 has a rate of 10 patients, so it could be another option. But if the patient is fit, then dosi plus trastuzumab plus pertuzumab if affordable.
Okay, okay. Sudeep, how do you choose in your practice?
Yes, sir.
Which agent to use? Trastuzumab, pertuzumab, TDM1, or let's say TDX also? Which agent to use? How do you choose in your practice?
Well, in fact, presently I have 2 patients like that, and I am using actually docetaxel carboplatin plus trastuzumab, and I did not. One patient completed total 6 cycles, another 2 cycles. So I did not have any FN event. So in my center, a lot of head and neck patients are getting the docetaxel and DCA, and we are confident enough to manage them. But FN is not an issue for us.
Okay. So fair enough. So the thing what I wanted to say is that we have multiple options. Normally people would tend to use a chemo plus trastuzumab first, and when the patient progresses, then to use pertuzumab or TDM1 or go ahead. In fact, the data for pertuzumab and is shown here, and you could see that the response rates are pretty good in these patients. The data for TDM1 also shows that the data for them also is good. They have good response rates, which were seen, as rightly pointed out by Satvik. This was only in 10 patients which were seen. With that, I would just stop here. And if there are any questions, I'll take, because I think we have already overshooted the time which we were given to us. If there are any questions, we would take.
Sir, adenomyocystic carcinoma, do you feel that after 6 cycles of CAP, putting them on lenvatinib maintenance is an option, or we need to wait for progression, and when patient is progressing only then we need to start lenvatinib?
So, Sudip, the way I see is we don't have much data that giving treatment in salivary gland tumors leads to an improvement in overall survival. So what I would do is I would wait for the patients to have symptoms, and when the patient has symptoms, at that time we treat. Because then at least we can do some amount of symptomatic control. As was shown by Akhil, lenvatinib is a good drug and gives you response rates around 15 to 20%. So I would exhaust it won't exhaust it on maintenance. That's my personal opinion. There's no data to either refute or confirm what I'm saying.
And sir, if one is progressing on lenvatinib, do you consider axitinib, or they have become already resistant to anti-VEGF?
So I'll tell you what I do in practice. I would get a biopsy in those patients and look for if there is a PIK3C mutation or a P53 mutations. Okay, if there are P53 mutations, the certain types of P53 mutations actually are angiogenic predictors. And if there's a PIK3 or a P53 mutation in that, then I would put the patient on axitinib. If they are not there, then I won't put the patient on axitinib.
Okay.
Yeah. In that situation, I actually take help of the way we do it in thyroid cancer. Frankly, there's limited data of cabozantinib in salivary gland cancer, but I have used cabozantinib in salivary gland cancer in patients who progress after lenvatinib.
Okay.
If there are no further questions, I'll hand it over to the organizers. Thank you.